Okay, everyone, we're going to go ahead and begin. So thanks everyone for being here today. My name is Gage Woolley, and I'm going to go ahead and try to do a little spotlight of myself so you can see my face. Perfect. Thanks so much. Really appreciate everybody being here today to do these webinars. Got a little intro for everybody, and then we will get right to it. So welcome to our Nurse-Driven Non-Product Innovation webinar presented by the University of Cincinnati Alumni Association and our College of Nursing Alumni Network. My name is Gage Woolley. I am the Program Director for Alumni Engagement for Nursing and CECH, which is the College of Education, Criminal Justice, and Human Services. Big mouthful. Great to see so many of you and so many familiar faces today. The UC Alumni Association is here to support the alumni success by positively impacting personal well-being and professional trajectory of our graduates. Our CEU webinar series session provides health and wellness resources, unique opportunities to learn about critical nursing topics, and tools to improve quality of life for UC alumni. Be on the lookout for more webinars, as we do have them throughout the year, usually around 6. Those next 3 will typically be during Nurses Week in May. A few housekeeping items. Please make sure you are on mute to prevent any feedback, any background noise. If you have any questions during the session, please type them into the chat box, or we will have time at the end, or we might stop it if it depends. It just kind of depends on what the question is. We are recording this session today, by the way, so the recording will be shared with everybody who registered in the next few days, in addition to a survey. We're going to ask you to fill that out. I will be the person you work with to obtain your CEU, so please do not message the presenters asking, where's my certificate? They won't know. I will be the one to help you with that. So without further ado, I'm really happy to introduce both Nick and Lauran today. So we're going to start with Nick as our introduction. Nick is a seasoned healthcare leader and entrepreneur with over 2 decades of diverse experience in nursing, healthcare operations, and business management. He was commissioned through the Army ROTC program here at UC. He entered active duty in the U.S. Army, where his service included deployment in the 10th Combat Support Hospital to Bosnia. After his military service, Nick transitioned into nursing roles. He later entered the home care health industry, holding various positions from visit nurse to director. In 2008, Nick founded a medical coding company, which he started with just 34 charts in its first month. Through consistent process improvement and a focus on innovation, by the time he exited the company in 2021, it was coding over 124,000 charts per month, with a staff of almost 700. Today, Nick is one of the co-founders of multiple startups and actively manages these ventures with his business partner. He also invests in and mentors other healthcare startups, with his current work involving consulting foreign governments and improving their healthcare systems. We also have Lauran Hardin with us here today. Hardin is the Chief Integration Officer for HC2 Strategies, focused on national initiatives developing and connected communities of care for underserved and marginalized populations. Her work includes partnering with IHI, Community Solutions, Center for Healthcare Strategies, and others to advance innovation and integration of healthcare and homeless response systems, cross-sector partnerships for vulnerable populations, and implementation of innovation in Medicaid. She was recently appointed as the first nurse representative and co-chair of the U.S. Government Accountability Office of Precision-Focused Payment Model Technician Advisory Committee. Thank you so much for being here today. Obviously, 2 very accomplished folks to talk about innovation. We're going to let you take the floor. Thank you so much.
Oh, great. Thank you, Gage. First of all, Lauran and I would like to welcome everybody to today's session. I'm thrilled to join you, especially as an alumni of the University of Cincinnati. I graduated in 1997. We've seen, incredible impacts of nursing that have empowered innovation approach that have gone beyond, traditional product-based solutions. Today, we're here to dive into the powerful concept of nurse-driven non-product innovation, an approach that leverages the skills and knowledge and perspectives of nurses to reshape healthcare delivery and drive meaningful challenges in ways that don't really rely solely on new technologies or devices. Today, we'll explore how nurses can lead transformation innovations to enhance patient outcomes, streamline processes, and address the unique needs of our communities. We thank the University of Cincinnati College of Nursing for this opportunity to connect with each of you, and thank you for joining us. Let's dive right in. Next slide.
Sorry, Nick, it's not moving. One moment.
As Lauren kind of works on that, I'll just kind of go over the next slide is the objectives. And so today's session will be exploring kind of key aspects of just the nurse-driven, non-productive or non-product innovations. First we're going to kind of clarify the difference between what is improvements versus which optimize existing systems versus innovations. Then we'll look into common barriers and helpful facilitators, for nurse-led innovations. Discuss effective strategies and skills for advancing those. And finally, we'll recognize the unique values of nurse-driven and non-productive innovations that bring us to in healthcare. So, bring up these slides here in a second. There we go. Okay, next slide. There we go. All right, so first what we're going to do is just kind of cover, what is nurse-driven innovation? Kind of the, high-level definition and the focus. Nurse-driven innovation is the process by which nurses lead and inspire new solutions, practices, and ideas that enhance healthcare delivery and patient outcomes. Unlike traditional product-based innovation, nurse-driven innovation often focuses on non-product elements, such as improving processes, workflows, and care models to meet patients' and organizational needs. The focus of nurse-driven innovation lies in leveraging nurses' unique insights and experiences. With their hands-on perspectives, nurses are in an ideal position to identify gaps, envision solutions, and implement changes that improve quality, efficiency, and patient satisfaction, all without relying solely on new technologies or products. These approaches not only empower nurses, but foster a culture of continuous improvement in patient-centered care. And we're going to give some examples of these kind of throughout the presentation. The importance of this, can you go back one slide? I'm sorry. Just kind of talking about kind of the importance of this a little bit is that nurse-driven innovation is essential because it aligns healthcare delivery more closely with patient-centered care. Nurses have direct understanding of patient care and can identify and implement changes that enhance the patient's experience and improve outcomes. This type of innovation can drive efficiency and quality improvement. By rethinking processes, workflows, nurses can help streamline operations, reduce waste, and elevate overall standards of care, by all of which are vital in today's health environments. There's a couple of different types of innovations in nurse-driven models. We talk about process innovations, care delivery models, education and training innovations. One of the things that you will kind of hear about is system thinking. Now, I'm a big believer that nurses are well-trained for system thinking. Innovation in nursing requires a system thinking approach, a skill nurses are trained in from the beginning. In nursing school, we learn the interconnection of organ systems, disease processes, and the importance of seeing a patient from the whole picture. Critical thinking is instilled in us, going beyond basic problem solving to help us analyze and adapt in complex situations. These skills can be directly applied to driving innovation in healthcare. And so to me, these are why, pieces that really make nurses ideal for thinking through innovation. Next slide. So there is a big difference, though, between, as we talk about what improvement is and innovation. So improvement is about refining what already exists to achieve a better outcome. It focuses on making incremental changes that boosters efficiencies, quality, or patient satisfaction. For example, reducing patient wait times by optimizing the scheduling system is improvement that builds on existing processes and delivers a better experience. Now, innovation, on the other hand, is about creating new solutions that disrupts a current model. It involves transformation changes, introducing entirely new ways of addressing challenges. For instance, developing new care models that integrates digital health tools. So one example that I will provide is when I was a performance improvement coordinator for a home health agency in the Dayton area, we were focusing on reducing rehospitalization rates. And we approached this from both an improvement and an innovation strategy. From the improvement aspect, what we did was our patients were received patient manual or books at admission time. And one of the things that we noticed was when our books had 911 big, bold on the front cover, and then our phone number, agency phone number, very small. And what we did was we reversed that. We put our phone number really big, and we also put, call 911 in an emergency, but a little bit smaller. And what we saw was patients started calling our agency first before they called 911. And our triage nurses were able to help prevent, patients going from the ER unnecessarily over a period of time. This allowed us to help better, make sure that patients, especially patients that maybe just were having some anxiety and wasn't really sure what was kind of going on, and prevented, unnecessary ER visits. From an innovation standpoint, we used our intake department to proactively call patients in between visits to kind of check on them. And this answered some of their questions. If they were feeling anxious and wasn't really sure what to do, sometimes those patients, in between visits would just go to the ER because they weren't really feeling good, right? So after you leave the hospital, you're not always feeling the best and you're feeling kind of panic, and you go to the ER. The ER doctor doesn't know you, they admit you, right? And so what we saw between implementing these two different programs, we saw a dramatic reduction in our rehospitalization rate. And this elevated our agency from the lowest qualifier rate in the state to the highest decile in the state over a 12-month period by implementing both of these two different programs. Lauren, do you have examples to kind of share about this?
Definitely. So I think the difference between innovation and improvement is really important. More than a decade ago, I created the first model that I worked on, was focused on high utilizing and complex clients that were accessing our system. And I looked at the data about the clients accessing our system who had high cost or high utilization. And what typically would have happened is the design of a care management model where you had people that were very good at complexity, taking on this population and directly intervening. What I did instead was actually design a role that became the coordinator and integrator for the community for complex populations. So I did not take them on necessarily as a complex care manager. I started to link people together cross sector, cross systems to look at the root causes driving their complexity, work on building bridges between systems and other services, and then really accelerating their access to evidence-based care. So going into spaces where an approach has not been taken can be super helpful. And then multiple years later, there's a lot of iteration happening on that sort of concept, which is more in the improvement space. But by taking a different approach and looking at what was missing in the delivery and then actually providing that, we were able to have multi-million-dollar reductions in cost and double digits reductions in unnecessary ED and inpatient visits, as well as addressing health-related social needs, which at the time people didn't do. We didn't screen for those. We didn't talk about those in the hospital, but we were able to link people to housing, to behavioral health, to address their anxiety and loneliness, and very different solutions because we had this cross-sector table for solving. So I think nurses are very uniquely positioned to really solve for some of the hardest problems in healthcare because of the way we see cross systems and cross disciplines, and just tremendous opportunity to bring forward our innovative ideas to really solve for what we need in healthcare.
Yeah, absolutely. And you know, and a couple other you know, kind of key differences between kind of, you know, the improvements and innovation. You know, innovation does take a little bit longer to kind of implement. You know, you know, sometimes it takes a little bit longer, you know, periods, and it could be a little bit higher risk to implement. And there's sometimes a little bit higher failure rates to implement. Failure is okay. You know, you learn from failure. And that's, you know, some of the pieces, you know, of, you know, if you don't try some of these items or some of these pieces, you don't learn, you know, from, you know, what works and what doesn't work. You know, I've sometimes, you know, we learn from, you know, from different conditions. Sometimes it's not the right timing. Sometimes it's not the right environment. Sometimes, you know, maybe it's not it's the right thought process. Maybe it's not the right patient population, right? So there's a lot of different things that when we try different pieces and we try to implement things, you know, we need to kind of learn and from all these different aspects as we kind of do this stuff. So next slide.
We'll see if I can get it to move, Nick. There we go. So considering the barriers to nursing innovation, I think is really important to talk about. There is an amazing array of new solutions to address the barriers. When Nick and I were first innovating as nurses, none of those resources existed. But these were some of the things that we ran into that we think it's helpful to call out. So first of all, internal barriers. I think organizational culture for nurses can be a really strong barrier to innovation because there isn't the support. So people may not be that interested in creativity or new solutions. When I started in my organization locally, I experienced a lot of resistance with that first model because I was doing things like leaving the building partnering with competitors, really looking cross-sector for what were the needs of the highest utilizing community members. And really, or from an organizational culture standpoint, at that time, the hospital was making a lot of money from the high utilization. So there was a big motivator to actually get in the way of innovation in that space. So thinking about organizational culture, recognizing where you are, but if you are in a culture of resistance, finding co-champions, people to partner with you, whether it's inside your organization or out. I ended up creating a complex care collaborative meeting that involved physicians that were impacted by high utilization, care managers, risk, people who cared about the issue so they could help me carry it in a context of resistance. I think there's a lack of voice, or nurses feeling like they uniquely have a perspective that needs to be heard. And I think we can support each other in that, but it's a personal change to really realize how you see this problem matters. And it may be very, very different than the traditional ways of looking at it, but that's what makes it so innovative and so valuable. Financial literacy is another component. I got into this because I was really interested in helping the population. I found as I began to know people's stories, it was really horrifying to me what was happening to some of the people, the inequities. So many people, their situations were actually pretty easy to solve for and really help them, but it was no one's job to do that. So, but in order to really do it well, I was driven first by values. I needed to learn financial literacy. So if I was going to be reducing revenue in my hospital of multi-million dollars, I was going to have to get very, very savvy about how to make the value case and really partner with finance. You know, I had a CFO who was very helpful to me and basically pulled me aside and said, you know why people aren't excited about this? You're dangerous to our bottom line. And he actually partnered with me to help me design the model so that we proactively mitigated some financial losses. So for example, I helped 100% of the uninsured clients that had high utilization. And I got them insurance if it was appropriate because it increased revenue and it balanced out the decrease in revenue for commercial clients that it was helping stabilize and reduce their utilization. So getting strong in financial literacy, being able to show the value case for what you're doing, but also understanding these are real financial levers that drive whether things go forward or not. And you can be angry about that or resist it, but they're real. And the more you understand them, the more you can build bridges to keep them from getting in your way. Time is a huge barrier, I think, internally for nursing with innovation. I've had a lot of different jobs now. I work nationally and I work with a lot of disciplines, and some disciplines, like physicians or others, they actually are allowed time to work on innovation as part of their roles. And for most nurses, that isn't the case. So you may be innovating in the back of your mind while you're in delivery mode or on the weekends. So time can be a barrier. And then just really thinking about risk tolerance. So you know, I had people that actively were fighting me from doing what I was seeing could be helpful. People did not want me to partner with competitors to meet the needs of clients. That was seen as like a risk to the business. Some people had issues where they didn't think I should be helping the people that were homeless, or that I shouldn't be helping the people that were transferring in from the justice system, or I shouldn't be helping people with substance use disorder because that was a personal choice on their part. So very different, you know, in working with complex care, it was definitely the lightning rod for resistance in all directions. So being clear about your own risk tolerance, and again, finding a tribe, finding people to walk with you to support your innovation. And then external barriers. I think equity is a very big issue for nurse innovation to be heard. So you know, it may not be designed into the system where you work where nurse innovation is supported, but also once it goes forward, you may receive a different response. So, and again, this was more than a decade ago, but I do see this pattern repeated as a nurse. Once I had built the model, it was very successful. I got $800,000 from an internal innovation committee to actually develop out the model and scale it to 6 states and multiple sites within our system. And that, I'll show you later some outcomes from that, but it was very successful. And once it grew to that point, people began to ask me, so when are you going to have a physician take over and run this model? And that was shocking to me, but it's a real cultural thing in our country, and I think that still exists. They're also on the other side for venture-backed companies and others that were waiting to see how much innovation did I put out, and then who could take it over then. So I had to really learn that was a thing. And the more I learned about that, and again, built alliances and partnership and learned how to advocate for myself in those scenarios, the more I could help clients and really scale this work. So market forces as well. I explained earlier about if I was helping these people, I was reducing revenue, paying attention to the impact of your innovation in non-product space. So if you're looking at care models, are you meeting a need in the market that's not being met? And if so, what are the economic levers you are impacting? You can have the most beautiful model that really helps people, but if you are not producing a benefit within that market system, you are unlikely to get long-term financing and support for continued implementation. So really getting savvy about understanding who are going to be my partners to help bring this forward, who are going to be my champions, and how do I bridge with the barriers in the market. Startup capital can be an external barrier, and I'm going to show you some resources where you can begin to learn how do you access that and get very savvy about it. There are many more internal innovation committees and like within universities, within organizations where they really are facilitating innovation. I was able to apply internally for that 800,000. But there's also a lot of people externally now who are interested in nursing innovation and their startup capital there. Competition is another thing. So as soon as you put something out there, and Nick probably knows this a lot better than I do, that as soon as someone sees something and it's valuable, they're going to copy it and they're going to replicate it in their own way. So getting very savvy about intellectual property and how much protection do you want to put around your model and the innovation you're creating. I had to get intellectual property lawyers and learn a lot about that because of the venture capital people that were in the background waiting to harvest from what I was doing. So I had to learn about that, but also learn about how do you come to that table. I was very mission driven, very ethics driven, very person driven, and I needed to build competencies to really balance out in light of that. And then also, as models are successful, really support for scaling them is a national issue across the country. Their financial support, but also people willing to put the infrastructure support beyond underneath scale, and so that people can be successful in replicating it and have a ramp to start. Nick, are there any things you want to add related to the barriers that you've seen? I think you have such an interesting diversity of experience.
Yeah, I think the biggest thing that I've run into over the years is when we come up with a new idea, is the phrase that I always get told is it's never been done that way before. And don't let that be a deterror, right? Listen to that, think through that, but don't let that be a deterror. And just because somebody tells you that, sometimes I use that as motivation.
It's a marker you're on the right path.
Yeah, exactly, right. And but that does, it does sometimes, hurt you initially, from an equity, and other stuff. But you have to go out there and show the proof of concept and all that stuff. But it seems like that is always one of the biggest challenges initially.
So true. So now there are many more supports Oops, now it's going further. There we go. Now there are many more supports to help you build those competencies. So when Nick and I were starting our innovations, literally none of this existed. We had an internal innovation department in this very large health system I worked in because our CEO had come from the Center for Medicare and Medicaid Innovation directly. So he put that in place, and he was a tremendous champion for me. When he saw the model, he basically said, "I've never seen anyone take this approach. Go forth and prosper, and here are the supports." Now you can access tremendous infrastructure, whether it's funding. So if you look at the Rita and Alex Hillman Foundation, they're funding many, many nursing models. You can find partners and other innovators to learn from on the CU Now podcast. There's nursing innovation fellowship programs, there's hackathons, and then there's a very robust suite of resources, both from Johnson & Johnson and the American Nurses Association. One of the things that was key for me, this didn't exist, but someone from AARP at the national level, from the Center to Champion Nursing, heard me speak, and they reached out and connected me to a mentor from the American Academy of Nursing, and that changed my life. Diana Mason took the time to be a champion for me, help answer questions. I had so many cultural things to learn, and she just repeatedly connected me to other innovators and people who knew answers to my question and knew about intellectual property and knew about this and knew about that. That if that hadn't happened, I wouldn't have been allowed to publish the innovation, and that innovation would have stopped in its tracks. And so those finding mentors is really key. And how about for you, Nick? You've been gone in so many diverse directions. Who's helped you?
Yeah, so to your point, there wasn't a whole lot, 14 some years ago. But what's been very exciting is a lot of the hospitals now, both domestic and international, have departments of innovation now. And I just actually ran into and have a meeting now with a venture capital fund that is nurse led, which is exciting. So there's, these are things that I've never seen, even 5 years ago. So there is a lot more stuff out there now, and and quite, one of the other great things, and you'll see, through like LinkedIn, through, networking, you will find just working with other, other nurses, ask, who are you talking to, and ask for referrals and ask who they're talking to, because you'll find that everybody is, willing to share, and we openly to collaborate and make introductions. I haven't really ran into anybody that is not willing to, to do that. So
Definitely ask. There's a lot of people that want to see this go forward.
correct.
So how about strategies for advancing innovation, Nick?
Yeah, so just some strategies, both either in your hospital organization, your businesses, just fostering these culture of innovation. You have to encourage openness and celebrate the small wins. It's sometimes we move so fast, and sometimes you forget the these small little steps that success, right? And make sure that you're always celebrating these small wins. Things, our society just is moving so fast right now. Build interprofessional collaboration. Lauren mentioned this earlier. We're talking about nurse-led innovation, but that doesn't mean that we're only talking with nurses, right? When I give one of my examples later, you'll see that, that includes physical therapists, occupational therapists, include physicians, include, maybe it's not even healthcare professionals. I include with my businesses now, I include, attorneys, financial professionals, as Lauren mentions, the healthcare, the financial literacy, the literature, understanding all the financial aspects and stuff like that. You just need to make sure that you're building this interprofessional collaboration aspect. Technology is moving so fast. Not only keep up with what is current, but keep an idea of what's on the horizon. If you're use a lot of the free stuff that's out there, if it's free, it's probably old technology, which is fine, but be aware that it's going to be outdated pretty quickly, right? It's good for, for the as you're kind of, testing out your MVPs, your minimal viable products and all that stuff, but be also aware of what is out on the horizon, because technology is moving so quick. When I started my first medical coding company, back in 2008, we were faxing still medical records. It's just, crazy, of how technology has just kind of changed over the years. Leadership and innovation skills. There's definitely, as we kind of talk about, and we'll get into a little bit more about some of the skill sets of, innovation and all that stuff on the next upcoming slides here. But there's definitely some leadership skills you need to have, which is you may come up with a great idea, but you may need a team to be able to get that idea to the next level, right? And, just because you have this great idea, you don't want to just, keep that idea and keep that, be so entrenched. I don't know what the right word is. Be so worried that other people are either going to steal your ideas or other people are going to give you feedback that you're worried that it's going to make your idea go in a different direction. Listen to other people, right? Because they may give you great feedback that it may, make your idea even better, as it grows. And then, and that kind of goes into this, innovation infrastructure, implementing this kind of feedback. So anything else to add, Lauren, on that?
No, I think that's a great base, Nick. And your next slide really starts to get into those competencies and how to think about them.
Yeah. And we covered a little bit this earlier about some of the system thinking, and really there's competencies for the individuals and the organization, and they're really kind of work in parallel. There's, as we talk about system thinking and, on the individual side, and then on the organizational side, the curiosity and the openness side of things. When we think about system thinking, understanding the complex healthcare system and how different pieces work, right? When we talk about the idea earlier about, a patient, calling 911, if they get anxiety, they get discharged from the hospital, they feel great when they were in the hospital because they were getting pain medication, right? Through the IV, they go home, now they're getting oral medication, now they're feeling kind of crummy, they start getting anxiety, they don't know, they're at home alone, Now they look at that book, they see call 911, they call 911. EMS people don't know what to do, right? So they send an ambulance. The ambulance comes, picks them up. They take them to the ER. The ER doctor doesn't know what to do with them. They admit them, right? All of a sudden, they're back in the healthcare system, right? So you have to understand that complex healthcare system and how all those parts kind of work, right? How do you break that cycle, right? That's that kind of that system thinking, right? Then how are we going to change that, right? And that gets right into that problem solving, right? And that it kind of just goes right down that whole process there. And as you start kind of going through that, you start figuring out how do you change that system, and you start implementing. And then how do you change that culture of the organization when they start saying, when you ask the intake department to start making phone calls and they say, well, that's not my job. And they said, we've never done this that way before. You got to show them how, why this is important and how we're going to test this out, right? And then you start showing them the data to be part of this data literacy part, right? And they start seeing the benefits. And all of a sudden, you start showing how this whole innovation piece works, right? And that's why you need all these different competencies to really show this kind of improvement. And then it just kind of goes right, the organizational side kind of follows that same piece there. But one of the pieces there is the reward for the innovation, right? Organizations really need to recognize and celebrate the successes. I also say that they need to, celebrate, if there's, failures. If there's an organization tried something, it doesn't work. Hey, that's fine. Let's try, something different. But let's look at why something failed. And maybe look at it from a different angle. So
It's so helpful. I think moving on to the examples could be the next best thing, Nick, because we can really start to see what does this look like when you actually apply it, and how did this happen for both Nick and I. So Nick, talk about how that played out for you in one of your innovations.
Yeah, so another product or another innovation that we did, then this was back at the home health agency again, was we had a challenge, and I don't know how many people have experience working in home health, but there's a standardized assessment tool called the OASIS. And one of the challenges that I identified was that the nurses and physical therapists and the occupational therapists, when they were scoring the OASIS, they weren't being consistent on how they were scoring. So all the nurses were, when they were scoring it, they were interviewing the patient. The physical therapists and occupational therapists were having the patients get up and move around. And so their scores for, say, ambulation and pain management, they were all being scored differently. They were consistent amongst the disciplines, but not consistent amongst between the interdisciplinary. So I sat down and we got a team together, and we came up with 5 different tasks that covered almost 80% of all the different OASIS items. And I'm not going to go through all those tasks, but basically what we ended up doing was we had those the groups. We trained all the staff to do this. One of the things that we did in order to get the staff to buy into this was I took 3 of the highest performing staff, and then I took 2 of the lowest performing, not lowest performing, but probably the 2 people that that we identified that would probably be most resistant to change within the organization and added them to the committee. And they were part of this committee. They actually started to see and understood the reason. We showed them the data, we showed them the reasons why we wanted to do this, and they bought into this. And then instead of me teaching everybody within the organization and me preaching to the 400 clinicians that we had why we needed to do this, the 5 clinicians taught everybody. And each clinician took one of the tasks and they taught. Because the 5 clinicians taught everybody, including these 2 that were known to be the most resistant to change of everything, all 400 clinicians bought into this innovative task. If you go to the next slide, and these numbers will probably be a little bit foreign, but I'll explain to you what they mean. Over a 12-month period, our case mix numbers increased significantly. And what these numbers really indicate is our reimbursement numbers went up significantly to like $1 million some reimbursement. Our visit rates went down and our quality scores went really high. So we showed that our patients were improving, our visits went down, and our reimbursement went up just by doing these consistent evaluations amongst. Now, did our patients were they any different? No, they were the exact same patients that we were seeing as before, right? But we had consistent data that our clinicians were doing. And so this is just an example of, an innovative way that, to make sure that our clinicians were, documenting properly.
I love how you use that nursing lens and you created tremendous return on investment, and you integrated the people that were highest resistance to this in design. I think that's a really brilliant principle. I'm going to quickly share a little bit about how I approached innovation, and then we're going to open it up for questions. So this is something we know now, but more than 10 years ago when I started this work, we were not looking at a holistic view of how people with complex needs, who the different sectors were that really were intersecting. So what we know now, and I've had the privilege of being part of developing the National Center for Complex Health and Social Needs, and this framework was developed nationally out of that, is that people need to have us think broader than just the healthcare system when we're working on solving for complexity. So really understanding what's happening in their health-related social needs, what's happening in their lives, and some of the structural things that are critical for health, like housing and transportation. So many years ago, I developed a model that was really focused on changing the system for complex patients. From an innovation standpoint, it turned some things on its head. So for example, it was not a building, it was a centralized resource. I used the electronic health records, and people could consult me like they could consult a doctor. People didn't do that at the time. And it really changed things on its head because I wasn't billing for that. So anybody could consult me, nurse assistants, physicians, specialists, anybody who noticed complexity. I was doing comprehensive assessment that included health-related social needs, but also assessed for breaks in the system. We were building cross-sector case conferencing to develop a shared plan of care, and that was integrated in the electronic health record and popped up with an alert. Once we learned from individuals that there were breaks in the system, we worked on pathways and process improvements, and we stood up community collaboratives cross-sector to work on things like housing and transportation. I partnered deeply with finance as well, and that model had a 23% return on investment. And that analysis was done by finance in partnership, and that was critical. to really show the value. Where that went from there was I joined the Camden Coalition to start the National Center, and then had the opportunity to partner with communities across the country and scale the same principles and see what happened. So I had the opportunity to work with Memphis on a model focused on the uninsured population using similar principles. They had tremendous outcomes, and they continue to. There's a BBC documentary about their model, as well as they won the Gage Award, and there's a Health Affairs article about it. Was able to partner with Lake County, California, very rural, 75% of affordable housing burned in the fires. That cross-sector group involved the police and fire and EMS and the mayor. So really pulling together an entire community to take a similar approach to complex neighbors, including those who had high utilization of the justice system and the 911 system. Again, very similar outcomes, same core structures, just applied in a different way. There's a peer-reviewed article and video about that. And then have had the privilege, and still am, working with St. Louis, Missouri, where they wanted to design a model that integrated all the hospitals in the community, focused on their highest utilizing community members with behavioral health, homelessness, and health-related social needs. Similar outcomes, again, seeing those core principles and structures resulting in improvements, and really people starting to think more in populations rather than my hospital, my behavioral health organization, my EMS system. They're thinking as a community, who's most vulnerable and who needs our help. So how that's played out, and you'll get these slides, but there's details and the outcomes and some quotes from patients. But where that's gone now, so now I'm working with an organization, and I'm continuing to partner with communities around the country, everywhere from Alaska to Maine to a big part of California. And right now we are applying those same principles. We have a contract with the state of California for 24 counties across the state, plus the entire state for Indian Health, where we're helping each of those counties develop a cross-sector approach to complex and underserved populations in implementing Medicaid innovation. So it's really exciting to see communities coming together, and that concept of developing a centralized resource to really accelerate that with some liberating practices, really having a big impact. So happy to share more, but we want to open it up for question and answer. And Gage, I don't know if you want to open the floor or how you want to handle that, but both Nick and I are really excited to be with you. I didn't get to say at the beginning, I live in Kentucky, even though my company's in California. So normally I'm like residing on my farm an hour from Cincinnati. So it's a true joy for me to get to connect specifically with the university here. So any questions or comments that you'd like to share from what we shared from our innovation experience?
That's perfect. We just open up to the floor for anybody. They can put in the chat, or you can use your mic if you prefer as well.
Hey, this is Rob Slater. Can you hear me?
Yeah, hi, Rob.
Hey, yeah, so I was curious because I work in the Air Force Research Labs. We have the 711th Human Performance Wing, so I saw this was coming up. So I'm also with the Small Business Directorate, so trying to find innovative companies. How do we bring them in? So part of my job is to help small businesses do business with the government. So we set up a bunch of, some successful, some not so successful innovation programs in small business area. And so I'm out of Dayton, Ohio. So was tuning in to kind of get a sense of what another industry might be doing, how they approach innovation, not just from, I'm on the technology development side, but also the process and everything else. So for me, it was just kind of getting involved and trying to better understand some of the things that are happening in healthcare that we might be able to translate, we'll say across the fence.
Very good.
Go ahead, Nick. That's so tied to you. I think there's such a parallel there with your work.
Yeah, I mean, it's and so you guys are doing a lot of stuff with are you guys doing a lot of stuff with like human performance type stuff up in the Dayton area?
Yeah, so my background, I'm an electrical engineer, so I'm more on the radar antenna side, but being in a more of a senior role now, kind of a broader scope look at things, especially being with small business. So we look at everything, and I joke with folks out there, that there's not much that you do that the Air Force doesn't. Right.
Yeah.
We go all the way down to the individual. How do we help recovery? How do we get them, fit to fight, all those kinds of things? How do we get them in recovery? So that's why healthcare is important, and, all the devices and widgets and spectrum and all the things you can think of, widgets, AI, you name it, we do it type thing. So
Yeah.
I'm always looking for new ideas. And part of my office is I didn't see this on your charts, but we own the Air Force's SBIR program, the Small Business Innovative Research.
Yeah.
And so each, it sounds like a sales pitch, but each industry, each department runs the SBIR program slightly different. And we've changed ours dramatically over the past 5 or 6 years now. And so, like NIH and NSF, those are notoriously hard to apply and get funding. Ours, for a phase 1, which is $75K for us, is a 10-page white paper, 15-slide deck. And we have an open topic. So we're looking for ideas that said, like, we don't know what we don't know. So we're looking for folks to say, hey, send us your good ideas. We'll connect you with some of our experts, see if that's interesting to them. And then, you apply for a phase 2, and that's up to, I believe, the last number I remember was like $1.5 million. And this is all non-dilutive capital, right?
Right.
And then phase 3, that is no money coming from us, but it's a direct contract with the Air Force. And so you can kind of think of it as IDIQ, if you're familiar with that term, indefinite delivery, indefinite quantity. And the value of those goes up to several millions of dollars. And we have matching. So if you've got, angel funding, VC funding, we'll match some of that under certain conditions. And so, yeah, we we just look for anything and everything, and a lot of innovation. We know it's hard coming out of healthcare in general, depending on what you define innovation as, but more the product side for us, right?
Yeah, it's interesting to hear you say that, because there's a lot of people trying to figure out how to get into the DoD, right?
Yep.
Because I know probably a dozen people that are trying to figure out how to tap into that market. And the other interesting part is my father used to work there in R&D at Wright Pat, but like 20, probably I guess almost 30 years ago, probably in the same area that you're at right now. So, but yeah, so there's we can probably talk offline. I'll reach out to you, but yeah, there's interesting. Probably trying to figure out how to connect networks together is probably one of the biggest challenges. There are so many, as Lauren and I kind of talked about earlier, 30 years ago or 20 years ago, there was just a few accelerators that were out there. And then over the last, 4 or 5 years, now there's so many different resources that are out there, and there's really not a whole lot of things that are talking to each other. And which on one hand is great that there's so many resources, but the other hand, it's like there's so many different silos that until you figure out certain networks, you can't figure out how to get into, say, the Air Force, SBR, right? You just don't even know where to start, for something like that.
TechConnect.af.mil, I think is the website. That gets you in there all the information you want. There's a submit an idea button. You go in there, at least for us.
Yeah.
And then it's the Heilmeyer Catechism, if you're familiar with that. Pretty much 6 or 7 easy questions. And we've uploaded our CVs, we've uploaded all of our information, our patents, papers and work we've been a part of. And so you put those keywords, those I joke and call them the 10-pound brains, right? You put those very technical terms in there, and I'm told AI, ML, NLP, all those kind of things happen in the background, magic in my world. And then they connect you with a SME, And so they say, hey, we like this idea. This is something we're working on. So while a SBIR may not be what you're looking for, they may have a contract vehicle to bring you on. They may be able to do an OTA, all these other non-FAR type, easy access type of contracts. CRADAs, and then the other one is an STTR. Those are two programs under the SBIR, the SBA program. The STTR is where you're working with a university and you're doing research with them, and then you come in and you're providing support to the university. The university's providing SMEs or tools or some function that's required for your research, and that's another channel to go under.
This is so interesting. I wanted, I know we're at time, but I'd love to stay on, if anyone wants to keep going. But Gage, is there anything you wanted to say as part of closure? We want to thank you all for coming.
Thanks for checking, Lauren. I have nothing particular to say. Just thank you for everyone being here today, and in particular to you and Nick for presenting this valuable information to us. You took a lot of time. I know, Lauren, you're in New York, or not New York. I forget what you told me, but you have 3 different, presentations, one in Chicago, one on here in Cincinnati, and then one, in somewhere else. So I'm just, grateful for both of you. Thank you both so much for taking time.
Thank you. And thank you so much, Mr. Slater. This is so interesting. If anyone wants to stay on and keep talking, I think it's fascinating what you're bringing up. So
yeah, I can go all day.
Thank you all for attending today. We appreciate the opportunity.